Just to start off for, Doctors Mulligan and Eckstein, there was, I guess, a two-part question from the audience about transplantation. And the questions were, you showed the data about transplant and about recurrence. Is how do long-term post-transplant outcomes for patients with PSC compared to other diseases? And in the context of living donation, is there any potential survival benefit for people with PSC to get a living donor?
I think the long-term outlook of a PSC patient getting a transplant is excellent. I think most of the people who unfortunately don't make it do so in the first year. So what you look at, what the outcomes are after the first year, that's maintained over long periods of time. So generally, it's a really good transplant. The long-term outlook is good, but the first year is really the year that decides who's going to be up there and who's the few that's just not going to have a good outcome. Overall, it's a very good outlook. The data for recurrent PSC is interesting because what I showed you is loss of grafts, not loss of people's lives, and it's because we transplant people again. But it's not everybody that gets recurrent PSC. I think we have to be realistic about it. It's maybe 10, 15% that gets it. So for those people, it's a very big deal. For the vast majority, if you don't get PSC, you get a good liver transplant, your long-term outlook is really, really excellent. And that's just why we do transplant, to get people back to normal lives. I don't want you to be half what you were beforehand. I want you to get you back to a normal life. So it's about quality of life and length of life, both as important factors.
Yeah, and to add on to that, as you published, David, from Penn in 2014, that the 5-year survival of patients undergoing liver transplant for PSC is significantly better than for all other disease processes. So it's clearly a very good disease to have a high success rate with transplant, save the 10% or so that develop recurrent disease, and they can be successfully retransplanted. So it's a very good disease. If it comes to that and you're not successful in preventing it to get to that stage that requires transplant is a good end of that cycle and to get back to a normal, healthy life. And there have been many, many patients who are living normal, very, very active lives today. One celebrity, well, two actually, Chris Klug, the bronze medalist, Olympic snowboarder, is a PSC patient. Also James Redford, Robert Redford's son, is a PSC patient, and they're both very healthy, very active, and very involved in trying to prevent this disease from getting worse.
Okay, we have a lot of questions. A lot. I'm trying to streamline them. A lot of them are related to transplant, so living donation. And basically, I can summarize many of these questions into what are the main things that exclude a person from being a donor for living donation? What are the main indications in the living donor donation?
So I guess sort of it's questions about, like, for a living donor, age, relatedness, things like that, who could be a donor. And then there were several questions about, from patients, is I have PSC, can I be a donor to someone else?
Yeah. Right.
We can split that up in two ways, and I'll leave the patient selection over here to David. I think when we talk about living-related donation, there's a few things that worry me, and I think we're very attentive to that. I think it has to be a liver that's freely given without anybody saying you have to do this. And this becomes very difficult in families where one person is sick and there's undue pressure being placed on some other members of the family. So that it has to be a free gift, and that person has to be allowed to say no. And I think most of our transplant systems are set up in such a way that our donor selection side is completely separate to our patients that we look after for transplantation. And we don't really talk a lot. We want to keep that as a separate entity because I don't want to have to split my opinions between a donor and the potential patient who needs it. So I think it has to be freely given under the right circumstances. And there can never be money paid for that. Yes, I accept if a donor comes forward and gives a donation, they're away from work and there's financial implications for them. But I think we get into difficulties ethically if somebody is saying, hey, I'm going to pay for you to give me your liver. And so that's something I don't think we ever want to see. And that's why our criteria has been very much, family and friends, close relatives. It's only very recently that we accepted anonymous donation. And it cannot be anonymous for you. It will be anonymous to anybody, because that anonymous to a specific person, we have no way of testing whether that's because of money changing hands. And what I do not want to see is somebody selling half his organ because he needs the money and then dies from doing that. I think that would be a disaster for everybody. So that's things that worry me. There are surgical considerations, and maybe David can touch on that.
Yeah, I think to add to that, it's a very complex topic, and I agree with you. I think many times we always consider relatives to be the ideal living donor. Oh yes, a relative, there's an emotional relationship, but oftentimes they're under the most pressure to feel compelled that I have to do this. And actually, when one thinks about it, oftentimes it's the friend, it's an acquaintance, or even an anonymous donor who's truly giving the most altruistic gift. And we do everything possible to try and prevent this from being a commodity, to be an organ for sale, for example. However, there are costs the donor has that are significant and shouldn't be overlooked. And so in the United States, just recently, to address this, there's been a huge move forward to try and reduce the costs on donors to be living donors. And as a matter of fact, just a week ago, the American Transplant Congress, Optum Health, which oversees United Healthcare, had announced, they're the largest coverage of all transplant covered lives, they just announced that they will pay for all the expenses related to a donor and their companion to travel to a center for living donation of their organs, and to have housing for any patient who's a patient under their insurance umbrella. And the donor and the companion do not have to have insurance with United Health or Optum, and they've challenged all other payers to match that and to step up to do that. So that's a big deal. Because when you look at the world and you look at the number of countries that don't have a UNOS and a really good organized system for deceased donor transplantation, the vast majority of transplants are from living donors. Now, the donor age criteria in general in this country, 18 to 60. However, a really young, robust 62, 63-year-old I have done as living donors and have been done elsewhere. I think that there's an increased risk when you get over 60 to undergo general anesthesia, so we have to be very, very careful to weigh those risks, and we don't want any undue risk to occur to a patient. They have to be healthy, and they have to be individuals that we feel go through a scrutinous exam medically, psychosocially, to make sure that this is going to be a safe operation for them. It's a safe time in their life for them to do this, and that we try to make sure as best we can that there is no perceived type of pressure creating a donation to take place. But it's not a perfect science. It's very hard to do that, and actually within the families it's the hardest to tell how much pressure there is. It's actually easier when there's no family involved, and you know that they don't have that stress.
Thank you. David, do you want to comment about the matching on living donors?
And I think Dr. Mulligan sort of, every center sort of varies, case by case basis. But you'll never know if you could be a potential donor to someone unless you ask, and reach out to whatever the living donor coordinator is at a given center, fill out the questionnaire, and they'll tell you.
Yeah, absolutely.
I'm going to switch gears just a little bit, then we'll come back to transplant. And there's a question for you, Dr. Boyers. How does the treatment of the disease differ between IgG4 and PSC? And does it change the need for transplant? Is IgG4 hereditary? And if so, how do you look for that? How does it affect donation?
Yeah, these two diseases have very different treatment. IgG4 disease is reacting on corticosteroids excellently, in an excellent way. Half of the patients with biliary tree involvement need long-term immunosuppressive treatment, but they can be controlled very well. We have in my outpatient clinic, there are about 70 patients with this IgG4 disease, and most of them do very, very well under a low-dose immunosuppressive regimen. Some of them came with a decompensated cirrhosis. They had too long this disease, and it was not identified. When you identify it early enough, the stenosis disappear within weeks under corticosteroid treatment, and you can go down with your doses very, very rapidly. It's not hereditary, what we know. We saw well that in our cohort, 88% of our IgG4 patients were blue-collar workers. They had contact with solvents, with diesel, with long-term, above 1 year, contact with solvents, with diesel, with paints, and so forth. So we have a new idea how this disease appears, but it's completely different from PSC, although the cholangiogram looks the same, and it's male patients predominantly. Did I answer all questions?
Yes. Bertus, can you clarify what's a chemical colectomy?
I think that's using some of our beta IBD drugs to heal up your bowel completely. So I think with a lot of the anti-TNF drugs we've got, or anti-adhesion molecule drugs we have for inflammatory bowel disease, these are all the injectable drugs, so they're either intravenous or subcutaneous. They've been the first drugs really to give us complete healing of the bowel. And so I think if you want to fix the bowel, you can either chop it out or heal it up completely, and sort of review that as a chemical colectomy using drugs to do that. And I think that heals it.
Along the lines of colonoscopy, we all know because of the high association between PSC and IBD, or inflammatory bowel disease, when you have your initial diagnosis of primary sclerosing cholangitis, we recommend a baseline colonoscopy with biopsies. Right. So one question we got here is, my son is 41. Because I have PSC, should he take his first colonoscopy at an age younger than 50? Is this an indication to do an early colonoscopy? And in my view, no, it's not. Right?
I would agree with that.
Yeah, no indication.
No need.
Not with symptoms.
All right. Chris, is there any treatment dealing with reversing of the fibrosis or reversing of the strictures, or is it all about preventing new ones?
That's a great question. Ideally, we would reverse the stricturing and the fibrosis. I think that's sort of the target of the Gilead study, although one of the difficulties we have is actually objectively measuring the amount of stricturing that's present in the PSC liver. Despite the advances in imaging that we have and the beautiful pictures we get on MRIs, we don't have a way of actually generating some kind of number associated with it. So to really show that there's a change is quite difficult. So ideally, we would like to change or have fibrosis regress, but I think we would be happy if we could just stop progression.
That would be great. Along the lines of treatment, the question is, we had the FDA ASLD meeting back in March. Have we come to any conclusion? What was the agency feedback about endpoints?
So I think Keith and Cyril are going to go over that meeting tomorrow. My takeaway was that we got some general guidance from the FDA, but as I was mentioning in the talk, we don't at this point have what they would consider a reasonably likely surrogate endpoint. They hinted that it might be a combination of, say, alkaline phosphatase and some non-invasive marker like FibroScan. But what we really need is to generate the data, the information that shows the FDA that, in fact, whatever marker it is, it's very robustly correlates with endpoints of liver transplantation or death. I mean, I think that's the bottom line of what their feedback was.
So going back to transplant, a couple sort of cholangiocarcinoma-related questions. So Drs. Eckstein and Mulligan, so you had mentioned that, you're still leaving some remnant bile duct there, and there's still that theoretical risk of cholangiocarcinoma. The question was, after transplant, should you be tested for cholangiocarcinoma even if you don't have recurrent PSC and you have some, minimal bile duct remaining? Is there any recommendations?
I think not. The risk is really low. Most transplant centers, when they remove the liver, will remove the extrahepatic bile ducts as well, so that all you're left with is a small chunk of bile duct that just sits by the pancreatic area and going into the small bowel. It's a very small area. Most of the data relating to the risk related to that are very old data, and it's more case studies. And there's some centers actually believe, well, maybe you don't even have to take the extrahepatic bile ducts away. So it's a risk, but it's not a very high risk. And I don't think there's a way that we can do it in a reliable way. So we could put people through a lot of procedures, a lot of scans and things without actually knowing anything what we're doing. So I don't think that risk is particularly high, and it's very, very difficult to test for it.
And I agree. I think when we do a liver transplant for PSC, in general, we remove the liver and the extrahepatic bile ducts together. That's the operation. We generally don't hook the native bile duct back up for biliary drainage on patients that have had PSC, especially if they've had cholangiocarcinoma. We generally make a Roux-en-Y so that we hook it so the bile drains directly into the small intestine. So whatever remnant of remaining biliary duct drains through the pancreas, there's no continued bile exposure, which we think changes some of the epithelial risk factor. We do, if the patient has had cholangiocarcinoma, do scans every 3 months and 6 months and 9 months so that we look for any recurrent disease, but we look for nodules coming back in the liver and in other areas. And remember, the patients that do well have had very finite sized mass at the hilum that's unresectable, not greater than 3 centimeters. They can't have had any invasion of that mass with a percutaneous biopsy. They can only have had disease limited to above the cystic duct, and it has to have been treated with the pre-operative or the pre-transplant radiation and chemotherapy plus an extra boost dose of either intracavitary brachytherapy of radiation through the bile duct or an external beam focused therapy. That's what really seems to make the difference in that recurrence in that subset of patients. Patients with more advanced disease where the cancer has spread distal on the bile duct, if we find it at the time of surgery, we usually add a Whipple to the transplant and take out the head of the pancreas with the entire bile duct. And those patients, if we do with a whole organ deceased donor transplant, can do well. But the more advanced the cancer, the less good the outcome. So we really try to be aggressive as we can on the early cancers that meet that criteria. And we do surveil them afterwards like any cancer patient to make sure it doesn't come back.
Just to briefly answer a couple questions, there's no specific upper age limit to be a transplant recipient. There are plenty of people in their 70s that are more fit than people in their 50s, so it's more just a global scale. To be a living donor, again, there's no upper age limit, as Dr. Mulligan said. He's had donors in their 60s. And deceased donor, again, it's what the liver looks like. There are deceased donors that are in the 80s that have excellent outcomes in the US and in Italy. It's been reported.
We had some great questions about development of artificial liver machine. What's the status of that? How about pluripotential cells or even 3D printers, which I found pretty funny. Nobody's laughing. 3D printer for liver. Okay, can anybody answer this question here about the status of the artificial liver?
Do you want? Well, yeah, actually, it's very exciting. We actually have a 3D bioprinter here at Yale, and we've been working on it. We're able to extrude stem cell produced blood vessels right now with branches in about 8 minutes on Nostratus. It's incredible, the technology and how quickly it's advancing. I can say I'm a reviewer for the abstract section that's dealing with some of this coming up at this next AASLD meeting, and there are at least 5 really good papers that are on dealing with the advances in bioprinting and how we can start to work towards cellular cellular regeneration and creating bioartificial livers. The research is moving forward. It's still probably a decade away before we're going to actually be able to print a liver that we can then transplant with the patient's own cells, but there's a lot of very exciting research moving forward in that regard, and I know at our center we're trying to work on starting to print bile ducts. That's never been done before, but I think it would be really exciting to be able to do that, and beautifully the liver cells are already built to regenerate, and they do that automatically. We don't have to pre-program that, so all we have to do is get the pipes all worked out and let them do the regeneration, and we'll be set.
Right. I think one thing, there was an organ donor summit at the White House a couple weeks ago, and one of the big initiatives announced there was the Department of Defense is putting out $160 million for research in regenerative medicine and cell therapy focused on organ transplantation, bone transplantation, and there was someone there talking about the sort of portable dialysis machine. So there is a push from the research community and the government to get more research to move this forward.
So we have some questions about pathophysiology, and if removing the colon can prevent or decrease the rate of recurrent PSC, does that mean that PSC comes from the colon? So we can have Dr. Boyers, you want to comment, and then Bertis maybe.
Yeah, Dr. Mulligan showed the slide of Dr. Newberger's group showing that when the colon was removed before transplantation, that these patients did barely develop a secondary, so second signs of a second primary sclerosing cholangitis. Unfortunately, these data were not confirmed by other groups. So this is a Birmingham observation and was not found in other groups. So the official recommendation is not to remove the colon before transplantation, but I completely agree, because there are several lines of evidence that there is a connection between the two, that you have to control the activity of the colitis very, very well in patients undergoing transplantation. So this is what I can comment on that. There is most probably, we haven't yet solved this problem, but what I also mentioned before, this gut-liver axis for PSC is probably true, particularly for those 70% of patients with PSC who have an IBD, but there are 30% who have no IBD. Maybe these are also different diseases, could still be.
If I can just add to that, I think when we talk about IBD as a group, we recognize there's lots of different types of IBD in there. There's Crohn's disease, ulcerative colitis, there's different patterns of Crohn's disease. And I think when we talk about PSC, here we tend to talk about it as one disease. But I think PSC has many faces. And I think colitis is more important in some forms of PSC. What happens in the bile is more important in yet a different subset. And so we're dealing with a disease that looks almost the same in most people, but is very different probably in how it's put together. And that's difficult, because when you try and make a drug that works for everybody, it doesn't work for everybody. And I think when we looked at the genetics of PSC, there are many different genes that give you susceptibility for PSC. So it might look the same to everybody, but I think there are differences within people and within disease.
You know, I have a question for you guys, if I might. We're talking about the microbiome of the colon and how that may be different. Is the microbiome within the bile different for patients that have PSC? Are there bacteria in patients that have PSC that is different than in patients who don't? And is that something that there's some research going on? So as just a dumb surgeon.
So in the paper that Dr. Beers highlighted about the FIT2 mutation, which really controls the environment on the surface of the bile duct cells of cholangiocytes. It controls how so sugars are cut and to an extent the bicarbonate umbrella on top of it. In that paper it was shown that depending on what version of the gene you carried, so which alleles you carried, your microbiome in the bile ducts were different. So I think This is a link to show how certain genes can control what happens on the epithelial surfaces, and that dictates your microbiome. So I do think there are some people where maybe the microbiome is the big problem, and that is different in certain individuals.
We've gone through most of the questions. There's one about the prevailing thought on why the prevalence of PSC is higher in males. And I don't know the answer to this one. I'm polling the group here, but I'm not sure. Does anybody have an answer?
I have no answer.
So, it is interesting because PSC is thought to be an autoimmune condition, and in general, autoimmune conditions are more frequent in women. If you look at things like PBC, it's 90% women. So, in there, we don't know why women are more, at risk, whether it's, hormonal, genetic, environmental exposures. I think we have a little bit of a clue there in that there may be certain chemicals in cosmetics, bacteria and urinary tract infections, but nothing like that we've seen in men. Maybe it is environmental exposures like the IgG4. Maybe men are more exposed. Another interesting thing we found, though, is that if we look at people of African descent, there's not such a male predominance. In fact, in the patients we've seen, it's really pretty even in terms of the distribution between men and women that have PSC. So it may also be that it varies from population or groups.
And Chris, if I could just add to that, it used to be very typical to say it's ulcerative colitis, it's a guy and has PSC. And really the group that's been expanding in my practice most are women with Crohn's disease and PSC. And so if you look at the ratio between women and men, it used to be way more men biased, and that's been changing progressively with more women catching up. And that's almost a large group of that is Crohn's disease in women. And so I do think there's some changes occurring through time in that demographic.
Yeah, just an example is a woman I saw just a couple months ago that had contacted us about a clinical trial. She was, in her late 20s, had been diagnosed as AMA negative PBC. So that doesn't make sense. Mm-hmm. So she had no history of IBD. She got an MRI. Turned out she has PSC, did a colonoscopy. She's got mild IBD. So I think there's probably a lot of those that are misdiagnosed as well because, they're, like you said, we think of this as a male disease when in fact there are women probably that are just not thought of having this condition.
Yeah. Now, in IgG4 associated cholangitis, the male predominance is even more striking, right?
That's really striking, between 80 and 85%. But this could be, if this is true, and we saw it in our Amsterdam cohort and in the Oxford cohort, that a lot of these patients have exposure to certain toxins, solvents or paints or diesel. And this was striking for us. So this could be a reason why it's a male predominance, because these were typically male professions over years, over decades.
So we'll have one final question, and then if any audience members have other questions, you can come up to the front afterwards. So Dr. Mulligan, I think you can address this. So the question was, kidney donation has paired exchanges where you can cross-donate to a friend and whatnot. There was a question: does the liver community have something like this? And has there been any thought, or what might be the sort of logistical challenges compared to kidney?
Well, that's a great question, and the liver community has thought about it, and we are doing something about it, and we need to make this happen. The logistics are complex, as it was for kidney. When we first started doing paired exchange, we used to try to have the donor fly to where the recipient was going to have their operation. And we've moved into a point where the donor organ can get recovered at a donor center and then the organ flown for implantation. For liver, it makes it a little more complex because the experience at the center where that living donor transplantation is going to take place are very important factors for the donor recipient, and the donor outcomes are very closely linked to the recipient outcomes. I'm sure you've seen that at your centers. And it's very important for the donor and the recipient to have some kind of proximity to one another as they're recovering. And so I would think, at least in the early aspects, the idea of paired exchange will grow out of lists at centers or within kind of some regional centers, and where it's easy enough for a donor to come to be at the place where the transplant takes place in order for that to happen. We may mature to a point where two really experienced centers like Penn and Yale, for example, or in Columbia and Hopkins, where there could be enough centers that are close enough where the donor surgery could be performed, the liver then transported to a recipient center for the transplant, and that's certainly a possibility. But these are things that we have to do in order to expand the opportunities for life-saving liver transplants.
Excellent. So thank you, all the speakers, for answering the questions, and the audience.
So is Toronto a lot more aggressive than LA and I mean, they're like,
Thank you. It's been a fantastic day. Our communities learned so much from all the international experts who spent time educating us on all aspects of PSC. I think it was just wonderful, phenomenal to have the opportunity to ask questions from this variety of experts and hear all their different answers. And also, you gave us a peek into the future, so thank you so much. And I want to remind everybody that we will have a video of today's presentations on our website once they're all edited. So now you're free until tonight's banquet. We all have a lot of information to start absorbing, so please take some time to visit with each other and relax. Dinner starts at 6 p.m. tonight. Please arrive in the ballroom and choose your tables. Sit with old or new friends. Tonight is open seating. Remember to wear your international attire and be creative. If you're a newbie, we get very crazy on Saturday night. And as our tradition, after dinner, we have karaoke, non-alcoholic karaoke, which actually is a lot of fun. So see you then. Thank you. Thank you, everybody. It's been wonderful.
All right.
oh yeah.